in international medical missions in Pakistan and Guatemala. So it gives me great pleasure to introduce Dr. Amina Tariq as the moderator, who will introduce Dr. Raema, and we'll start our presentations from there.
Assalamu alaikum wa rahmatullahi wa barakatuhu. I am the co-moderator on the female side, and a brief introduction on myself is that I am a diagnostic radiologist working for many years at a VA in West Virginia. And I am very happy to introduce today Dr. Raema Mir, who is a family medicine physician practicing in New Jersey. She earned her medical degree from Drexel University College of Medicine, then went on to complete her residency at Christina Care Family Medicine Residency Program. She now serves on the Physician Wellness Committee at Virtua. Dr. Mir values the relationships she builds in primary care, enjoying the opportunity to hear her patients' stories and support them throughout their health journeys. She is passionate about health education and enjoys sharing medical knowledge with both her patients and her local mosque community. Outside medicine, as a fun fact, she not only takes care of her 3 children and tries to feed them by making new recipes, trying new recipes, loaf cake recipes, watching Korean dramas, studying their culture, and reading whenever she can find time. And I would also like to mention that in 2018, she was listed as a top female doctor in family medicine in the area. And she also served as local Lajna Sadr in Willingboro, New Jersey. And now we can start the presentations, the combined presentations between the 2 presenters.
Ahmadu wa nasalli ala Rasulil Kareem, Bismillah ar-Rahman ar-Rahim. And of his signs is the creation of the heavens and the earth, and the diversity of your tongues and colors. In that surely are the signs for those who possess knowledge. Surah Rum, chapter 30, verse 23. Jazakallah, Dr. Tariq, for that introduction, and Assalamu alaikum, and Jazakallah, everyone, for who's attending today. The verse that I just read the translation of is noting signs to recognize Allah. And in this verse in particular, there's the mention of this creation of this beautiful and complex world. And also, Allah has mentioned traits that make us differ from each other, so our tongues and our colors. However, under all these traits, we are all humans, coming from the same root and source, which is Allah. As there are many things that we do not understand about the world unless we really research or dive or learn more. For example, we might not know how one species might be important to another species or important to maintaining an entire habitat, or how we might not know that Allah has put certain healing properties in a plant or an animal. In the same way, we may not know how another individual may be able to help us or offer something to us or even the entire world. And this verse is telling us to be open to all of these differences. Going along with this message, we are speaking about neurodiversity today. Under this, neurodivergent refers to someone whose brain performs differently than what society considers normal. Neurodiversity does not refer to one individual, it refers to a group of people containing neurotypical and neurodivergent people. The concept of neurodiversity recognizes neurologic and developmental differences as part of human diversity. Challenges experienced by neurodivergent individuals are due to a mismatch in society's expectations and biases. Neurodivergent conditions typically refer to lifelong conditions that have significant effects on how individuals think, process information, and make decisions. For example, some conditions are autism and ADHD, which we'll be focusing on today. We can go to the next slide. We can go to the next slide. So we can see here, there's a picture, a diagram, and it's highlighting different conditions that are common under the neurodivergent umbrella, or the neurodiversity umbrella. So there's conditions such as autism, ADD, dyslexia, dyspraxia, Tourette syndrome. These would all be conditions under neurodiversity. And we can also see some positives listed here with these different conditions, because when we're normally thinking of these conditions, we might think of the negative outward manifestations, but certain things such as someone with ADHD might have creativity, or someone with autism might be able to really focus in on something in a way that someone who's neurotypical may not be able to. So the thought is that being neurodivergent can bring challenges, but also positives, which are ignored if you think of the issue as normal versus abnormal. For example, as I said, people who are neurodiverse might bring a unique perspective, may be able to do creative thinking. They might be able to have a sensory sensitivity that allows them to really get pleasure from a sensation that wouldn't be possible for someone who's neurotypical. So we can actually go to the next slide. So in our presentation today, Dr. Sheharyar, Sarwar, and I are going to be focusing on two conditions. One is autism, and the other is ADHD. So I'm going to start by speaking about autism. So you can go to the next slide. Am I supposed to have a clicker? Okay, I'll just keep telling them. So in medicine, we use this this manual. It's called the Diagnostic and Statistical Manual of Mental Disorders. I'm going to refer to it as the DSM during the presentation. And so it has a very descriptive definition of what autism is, and it uses the medical model to describe it. So it's using outward manifestations to describe what autism is, and it's mainly focusing on the negative impact. So we're not going to see the positives mentioned here. I'm just summarizing on this slide some basics, general summarization of what's in the DSM. So I'm just going to read those points. So in autism, there are deficits in three areas of communication and social interaction across multiple settings, with at least 2 restricted or repetitive behaviors. And these factors are not explained by another condition, and also cause functional impairment. So autism itself is something that we should know about, because it's relatively common compared to other conditions. So 1 in 31 children and 1 in 45 adults in the United States are thought to have autism. You might be hearing about it more often. So there's increased prevalence over the years, likely associated with changes in the diagnostic criteria, improved performance of screening and diagnostic tools, and increased public awareness. In the past, you might have heard terminology such as Asperger's syndrome or pervasive developmental disorder. We don't use these separate terms anymore. They all just come under autism. The terms high functioning and low functioning autism aren't used anymore either. The new definition, the DSM, describes it by severity level, and there's 3 severity levels separate from cognitive functioning. So level 1 needing some support, and level 3 needing substantial support for daily living. So another thing I wanted to point out on this slide was when I was in medical school, I was taught you separate the disease from the patient. So it's not a diabetic patient, it's a patient with diabetes. However, due to the neurodiversity movement and the belief that this is just a variation in a possible variation of normal development, that people with autism are considering this part of their identity. And so some people prefer actually just to say it's an autistic patient, autistic person, and they prefer that you say it that way. And so it's important to communicate with your patient and find out where they are on that. Next slide. So when diagnosing autism, we should use a multidisciplinary team and multidimensional assessment. The American Academy of Pediatrics recommends screening from autism for autism at ages 18 and 24 months, in addition to doing routine developmental surveillance. And in adults, there's no recommendation to screen an asymptomatic adult. The most commonly used screening tool is the modified checklist for autism in toddlers. So this is in pediatrics. It's called the MCHAT. It's a widely available, accessible, and a screening tool that's been translated into several languages. And it's been assessed and validated in the primary care setting. So it's often used in the pediatrician's office at those ages to screen for autism. However, in addition to that, you also want to pay attention to what the parents are telling you. So if parents have concern about their child's development or that they may have autism, you want to hear those concerns, because even though we're doing screening at 18 or 24 months, signs of autism can appear even earlier than that, even as early as 6 months. And then as for adults, they may be functioning normally in the world, or they may be functioning and not creating an outcry from other people around them, but people still want a diagnosis at times because it helps them network with other people in the autistic community, also gives them access to other resources that are out there. So sometimes a patient might come and say, oh, I think I might have autism, or I've been doing this to try and figure this out. So there's no general screening recommendation for adults, but obviously if someone's coming in with concerns, then you want to address that. There's a recommendation from the UK National Institute for Health and Care Excellence called NICE, and they recommend this questionnaire AQ10. It's a 10 question questionnaire for people who are without cognitive issues, coming in saying that they're concerned about autism. So then you can do that questionnaire with them and decide, yes, it makes sense to proceed with further testing, or really you're not meeting the criteria. So this next slide, I have early symptoms of autism spectrum disorder. So again, as I was saying, sometimes symptoms can occur before 18 months. So at 9 months, if a child does not respond to their name, does not show facial expressions showing that they're sad or happy or angry, that's a little bit weird. At that age, they should be doing that. And then following along with that up to age 5. So if at age 5, the child isn't singing, dancing, doing some type of acting, play acting, then that's a little bit weird and you should be concerned and maybe need to investigate that. You can go to the next slide. So this one has just some general symptoms of that you might see in autistic patients. There's like a huge list here of different things that might be happening. Not all of the autistic patients are going to have all of these symptoms. So I read this somewhere. If you met one autistic patient, you've met one autistic patient. But on here, we can see some common features. So for example, at the top, it says avoids or does not keep eye contact or may want to be alone. Another one listed on here has obsessive interests. So the patient may be not interested in having a day-to-day conversation or talking about how the weather was, but if you get them on their special interest, which is maybe trains or something like that, they'll know a lot about trains. They'll know when different models were made. They'll know when they were taken out of, action. They'll know a lot of details, and they'll be able to talk about it really well. Another thing often is that they may not pick up on social cues, or they may take things really literally. If there's like a party going on and everyone's supposed to go bring a dish, they might not realize they need to bring a dish unless you specifically tell them they need to bring something. So other stuff being also, some patients can be nonverbal, non-speaking, have atypical speech patterns. Some of them do this thing which is repeating sounds or phrases. It's called echolalia. Some of them have repetitive movements. Oftentimes, it can be tough for them to transition in the schedule or have changes in routines. Some of them are extremely sensitive to light and sound. Some of them are extremely sensitive or don't have less sensitivity to certain stimuli, like pain, for example. Go to the next slide. So as far as autism is concerned, I thought this was a very impactful fact, which is that documentation currently is that they have 20 to 30-year lower life expectancy. So as a physician, that diagnosis is important. Causes may include an increased burden of co-occurring medical conditions, mental health challenges, systemic barriers. Oftentimes, patients may present late for care. My husband works in the emergency department, and he related a story where a patient came in with a foot fracture, but the only reason they brought him in was a caregiver noticed that he had a broken foot, so they presented late for that. So most common cause of death in autistic children younger than 15 is unintentional injury, with leading causes being drowning, suffocation, and asphyxiation. Among individuals with co-occurring intellectual disability, complications from epilepsy tend to be the most common cause of death. And then in autistic patients without intellectual disabilities, suicide is the most common cause of premature mortality. So definitely things that we want to keep on the radar when we have a patient like that. Autistic individuals are at significantly higher risk of being bullied, mistreated, and sexually abused. So the point is that autistic individuals are more vulnerable, and changes in society are needed to reduce this risk. So definitely, I think there have been increased resources for our children and at the younger age level before they're an independent adult. But as you get older, you go across that threshold, you see a significant reduction in resources. So definitely a place where we can work on. And then another fact that I wanted to mention is that disability and underemployment and unemployment have been repeatedly linked with reduced life expectancy. And this is a common issue for the autistic population. So 1/2 of autistic adults are unemployed and around 30 underemployed, and around 38% are unemployed. So next slide. Causes. So American Academy of Pediatrics recommends that a genetic evaluation be offered for all families of autistic children. Even if there's not a direct gene, I guess that's identified, it does tend to be more common within families. Environmental exposure that has been associated with higher risk of ASD include prenatal exposure to neurotoxin medications such as thalidomide and valproate, and infections such as rubella and cytomegalovirus. And then this last point I think was really important. There's been a meta-analysis of cohort and case control studies involving more than 1 million children found to have no association between vaccines and autism. So this is a common misconception that's out there. And I think even in our community, there's some hesitancy against vaccines at times. So I think that's an important point that this is well researched. So we can go to the next slide. Treatment. Treatment of children with autism spectrum disorder focuses on minimizing core deficits, maximizing functional independence, and preventing problem behaviors. Pharmacological therapy may be indicated for related conditions or symptoms such as sleep disorders, seizures, mental health conditions, behavior problems, and gastrointestinal issues. So underlying thing is there's no cure for autism. And with the neurodiversity concept, the thought is that we're trying to meet patients where they are to help them be able to meet their goals. And also what you'll see is that if we're able to provide resources for them, make the environment less stressful for them, they're going to be able to do more and be be able to contribute more. But there's no one medication that's going to cure them. Melatonin effectively reduces sleep symptoms and improves daytime behaviors with minimal adverse effects. And then we can go to the next slide. So I did want to mention one framework that may be helpful for people, our clinicians. Really, this it's called the SPACE framework, but it can be helpful, I think, not just for patients who are artistic. It kind of makes sense once we go through it. So the SPACE stands for sensory, predictability, acceptance, communication, and empathy. And we can go to the next slide. So under sensory come all our senses. So for example, if we're trying to make the room more accessible and comfortable for an autistic patient, they might be bothered by flickering lights or glaring lights. And so having something that's a little bit more neutral, colors that are more neutral, trying to avoid having strong senses, so wearing strong perfume or having the room be near, your cafeteria or something where there's smells coming, trying to avoid that. Trying to make sure the room isn't too cold or too hot. And there's predictability at the end of here. And then we can go to the next slide, predictability. So like trying to make sure that the schedule is what it's going to be very open with communicating with them about the time of the appointment, if there's delays, being very open about that. And then if you do have to change your schedule, to try and minimize disruption for them, because it's going to impact them more than another person. Yes, and then we have on here acceptance. So again, there might be behaviors that someone who's autistic might be doing to help themselves. So the stimming, like repetitive motions. So kind of being accepting of that, right? Communication. So sometimes autistic patients can be very literal. So you want to make sure that you are not using, similes and metaphors, and being very direct in what you're trying to communicate with them, and maybe having them communicate back to you. Some patients may have preference to have things written down, or for that you to even speak to their caregiver or someone in their life, so that everyone can make sure that they come in on the same page. I have some patients that come in with a parent, even though they're an adult, they'll come in with the parent because of that. um, so things like that. Um, Physical space, they might need some space, some time to answer questions. So they might seem like they're taking a little bit of time, but giving them that time, because then that'll help them be more open to you. Um, yeah, so, and then we could go to the next slide. So I have some resources on here. There's some websites listed on here, and organizations. So there's the Autism Society, which is pretty easy to Google up. um, Autistic Self Advocacy Network, which is, I think, is very interesting. They have, they're advocating for themselves. So there's some information on there about that, and also resources and how to connect with each other. And so these are just some websites that I had that might be useful resources. And I'm going to pass this over to Dr. Sarwar.
Jazakallah. So on the topic of neurodivergence, we're going to talk about ADHD, which is the most common form of neurodivergence. And it's very common across the globe. More attention's come to it of late. It's caused by many factors. Genetics is probably one of the most important factors for attention deficit hyperactivity disorder. It's right there with bipolar disorder as probably having some of the most genetic prevalence as far as psychiatric conditions are concerned. Other causes like nutrition, trauma at birth, immune disorders also exist. It's most commonly comorbid with other neurodivergent conditions such as autism, most commonly associated also with Tourette's and OCD. So what is it? It's a pattern of behavior and cognition, and it affects your daily function. And there's three kind of categories: attention, impulsivity, and uh, mm, hyperactivity, so activity levels. So inattention wise, it's an inability to focus, inability to sustain focus, and not having the patience to be able to focus, and being easily distracted. Hyperactivity wise, it's going to be restlessness, fidgeting, inability to stay in one place for a long period of time, whether it's leisurely or whether it's a task, and impulsivity, kind of reduced breaks, kind of as far as kind of thinking about the consequences of actions before committing actions, increased risk taking, and also emotional discontrol, which kind of falls into that impulsive category. It's very prevalent. So these figures are for folks who've been diagnosed. So about 11.4% of the children in the U.S. as of 2022 have been diagnosed with ADHD, and then about 6% of adults are diagnosed with ADHD as of 2023. The couple of patterns that have been noticed is that there's an inverse correlation with socioeconomic status. So lower socioeconomic status means that there's a higher prevalence of ADHD in those communities, also more prevalent in Black and white communities as opposed to Asian and Native American communities, and also more prevalent in men. So diagnostically, it's split into two sets of symptoms. There's the inattention symptoms, and then there are going to be, following this, there's going to be the hyperactivity symptoms. So if you demonstrate 6 or more of these symptoms for a period of 6 months or more, then you would qualify under the criteria to have a form of ADHD. So essentially, inattentiveness, what people really struggle with here is the inability to focus for an extended period of time, the inability to kind of understand instructions. They have a lot of difficulty understanding, repeating back instructions. They forget what homework they had, they lose their homework. There's difficulty with being punctual. There is a lot of mistakes and carelessness. There's a lot of losing of their belongings or things that they would require to be able to complete their work. And so if you have a combination of that and it hits, approximately 6 of these, then you would kind of fall under the or meet the inattention criteria. The hyperactivity criteria is similar, that you need to meet 6 and you need to have about 6 or more for a period of 6 months or more. And they're often, what you'll notice is they have a lot of difficulty sitting in one place. They have a lot of difficulty remaining in place, even if it's for something that they enjoy, such as watching a movie. So, inability to relax leisurely and also relax or stay in place for a task. What you'll notice is that they have difficulty waiting their turn. So things like standing in line, things that waiting their turn to speak, they are constantly being described as disruptive and sometimes rude because they cannot wait their turn. They also may be fidgeting constantly. So when they're seated in place, you may notice that almost to keep the rest of their body still, something is moving, like they're flicking a pen or they're flicking their foot, and they're constantly readjusting. So if you meet 6 or more of these, then you also meet the hyperactivity criteria for ADHD. So one of the other things that's part of the diagnosis is that these symptoms, they shouldn't just spontaneously show up. If some of them need to definitely be present before the age of 12. So if you have an older individual, having history from their family is pretty important for this diagnosis. um, and then these need to occur in several settings, right? So in the world of mental health, when you're thinking about dysfunction, oftentimes we don't just think about dysfunction in one setting alone. It has to be persistent. It has to be present in multiple settings. So these symptoms also, they just cannot be in one classroom in their school. They need to be at home, they need to be in their classrooms, etc., for you to be able to say that, okay, this dysfunction persists. The other thing to think about is that they cannot be um, explained by other mental health conditions. So comorbid depression or anxiety or schizophrenia or bipolar disorder, all of these other things that may affect people's ability to pay attention and cause people to have varying levels of activity or hyperactivity, they cannot be the primary cause of this. So you have to exclude other conditions to be able to say that this person has ADHD. And finally, dysfunction. So whenever we're talking about any mental health condition, you could have a patient describe to you the exact symptoms of a depressive episode or the exact symptoms of ADHD and say, I have every single thing listed. But if it's not affecting their life and it's not causing them dysfunction, then it's not a disorder. So therefore, that part is important as well. How is this affecting you? How is this affecting your ability to complete your work, your school tasks, and your life at home? There are variations to the diagnosis of ADHD. So, for instance, you can have predominantly inattentive or hyperactivity type or combined type. And then, obviously, when you're talking about dysfunction, you can talk about the severity of these symptoms at the same time. So oftentimes there are self-reporting tools. So the adult ADHD rating scale is a pretty good tool. Patients, like I said, it's a self-reporting tool. So you give it to patients, patients will fill it out. It's often a good idea to give it to a spouse or a parent at the same time to get a realistic view from them as well as to see what the patient is experiencing, because oftentimes you'll see that there is a variation between what a family member reports and what a patient reports. I'm not saying that patients always over-report. It happens both ways, but it gives you a good collateral when you're looking into diagnosing ADHD. You can also do what's called a structured interview based on DSM-5. If you are in the primary care setting, these cost money and they can take a long time. What I would say is use your clinical judgment. So if somebody's coming in and they're telling you they've got severe ADHD and they're endorsing all of these symptoms, look to see if they're truly, you know, while when they're sitting in front of you, if they have attention deficits, if they have difficulty staying on task, if they're kind of um, easily distractible, if they are fidgety, if they are a little hyperactive, these are things that you're going to notice. If somebody's coming to you and they're more organized than you, and are able to have a better linear conversation and remember small details of the last time you met them, even things that would be pretty difficult to recall, that's attention to detail, and that's that may be somebody where you don't take even the self-assessment at face value. So using your clinical judgment is always going to be very important. Obviously, if you're a primary care doctor and you're noticing somebody and you just can't figure that out, refer to a psychiatrist or a mental health specialist. One trend that I have seen, particularly even in individuals who have ADHD, trying to get a diagnosis of ADHD, and then also primary care doctors who are seeing patients with ADHD, is they want to go for neuropsychological testing. Neuropsychologists are probably among the rarest form of specialists in the psychological world. An appointment takes like 3 hours. They are always backed up, and so both for your patient and for you, it may not be such a great idea because it'll be impossible to get an appointment, and then you might delay care by several months by requiring this. So if a case is pretty straightforward and there's good family information or information from family stating that the patient has symptoms that are consistent with ADHD, and also there's a strong history of like genetic component, as in mother, father, sister, brother have ADHD, then it's okay to then go ahead and start treatment for ADHD. Treatment-wise, the first line treatment is stimulants. So when you think about it, stimulants obviously are a drug of abuse as well. They cause a release of dopamine and epinephrine, and they are associated with stimulants such as cocaine and methamphetamine. Obviously, are also stimulants, but these are controlled substances that have good treatment for ADHD. So most commonly, you guys have probably all heard of Adderall, and then you've heard of other stimulants like Ritalin and Vyvanse. So these are all first line for ADHD. Non-stimulants, so when you think about them, the FDA-approved one is something called atomoxetine. It's a medicine that is affiliated with a group of antidepressants called selective serotonin and noradrenergic reuptake inhibitors. And then non-pharmacologically, there are various things that are available, like cognitive behavioral therapy for ADHD is available, mindfulness techniques, which certainly bring one, into the present moment, and then ADHD journaling, which is a way which teaches patients to kind of organize their schedules so they can be on time and kind of have a plan for the day. Things to think about as you are providing this care is that you want to do regular follow-ups because you are prescribing, if you are prescribing stimulants, you are prescribing controlled substances, but otherwise you also have to monitor them. So federally, it's a requirement that patients have to be seen every 90 days for a heart and lung exam in your clinic. So at least a heart and lung exam. It says a physical exam, but you need to have at least a heart and lung exam every 90 days documented in the patient chart. So that's a requirement that a lot of people miss or don't know about. So just look into that because that's a place where you could get yourself into some trouble if that's not kept up with. Um, Obviously, monitoring for efficacy and side effects. Also, just be aware. Just kind of have your spidey senses kind of focus on any possibility of divergence of medication, because these medications do often get diverted. Patients can also get them from the street, and they do, and it's also they're often there are um, patients will fill them and then sell them on to sell them on for profit as well. So that's something to consider. Um, Risks wise for these medications, it's obviously important to let your patients know that there is a very rare but possible side effect of cardiac arrest, particularly in younger folks, so people under the age of 30. And then also, if they have a recent MI, or as in a recent heart attack, or arrhythmias, or uncontrolled hypertension, it's not a good idea to prescribe these medication. So considerations are for ADHD patients. I mean, obviously these patients are struggling with attention, and and that translates into the things that you're going to be telling them too. So make sure you have them teach back all your instructions. Make sure you write down the instructions for them, and also when you do that, make a copy of yourself of the exact instructions you gave them as well, because oftentimes what you'll notice is that you might get frustrated with them, because you might think that you gave certain instructions, they might remember different instructions. So it's a good idea to give them a copy and keep a copy of the exact instructions you gave them for yourself. Um, Sometimes, also just like I said, telltale signs and symptoms of ADHD may be somebody who's obviously very scattered during the interview, somebody who's constantly fidgeting, and then also one sign that oftentimes you forget, because it's easy to think about it as something that annoys us, is that they may be often late, or forget about the appointment. So I know that that's something that where we would be like, oh, this patient is just not caring about making it to their appointment and are irresponsible, but we forget that that could be very much a sign of ADHD. So there's some resources here for the parents. These are some very good websites to look at. They describe ADHD, and what should families and parents think about. What I would say is, as we're talking about the neurodivergent um, model, and we're looking at the goal of the neurodivergent model is to make sure that we provide resources, the type of care, the type of understanding that will allow these folks to be able to function as best as they can, their best version in society. One of the things that I want parents to think about particularly is that when you have a child who is struggling with ADHD, or one of the other forms of neurodivergence, or even depression or anxiety, one of the things you'll notice is that you might find a child who is being defiant or rude or hyperactive or aggressive. That's because there is sometimes a lot of difficulty in explaining. Even as adults, we have difficulty explaining our internal experience. So for kids, it's particularly difficult. It's a prevalent condition, ADHD, and other forms of neurodivergence are as well. So, as you are experiencing sometimes, difficulty with your child, consider a possibility of having them being seen by someone, just to get a second set of eyes to see if they might be struggling with something that you have difficulty identifying and they have difficulty communicating with you. Because what you may end up doing is causing a lot of tension between you and your child by thinking that they're misbehaving, they're being a bad kid, right? And they might actually be struggling with something that you could help them with, and that would strengthen your relationship moving forward and an understanding. And that's kind of the gist of kind of when you think about neurodivergence as a whole as well, is that we're just trying to understand what these folks are going through and making you know s- um, an environment, creating an environment for them where they can be comfortable themselves, feel like they're accepted, and be able to contribute to our society in a way that is meaningful for them and for us. And like I said, their divergence, and Dr. Mir pointed this out, also creates um, an opportunity for a unique perspective, right? So if we create the right environment for them, they might help us change the world in a way that we never thought of. Um, and that's all I have. Jazakallah.
Assalamu alaikum, everybody. We have some time for questions. Dr. Tariq, I think I'll hand over the mic to you, and we can start questions and discussion from that side first.
Jazakallah. From ladies, are there any questions? Please come forward. Introduce yourself first.
Oh, my name is Gakab Zerbi. So I have two questions actually. One question is for Dr. Mir. So for a particular autistic individual, I understand there's a lot of variability in the different features they all possess. But within their lifetime and development, do they generally stay static? So if they were diagnosed at adolescence and as time goes on, they grow into adult, do we generally see those same features and we try to accommodate and alleviate them with the environment? So that was my first question. And I don't know if I should go in the second. Okay.
Dr. Mir, if you can respond.
Assalamu alaikum. I'll briefly, I guess, answer your question. So definitely, if we can intervene earlier on in childhood and identify the issue earlier, we can probably help, depending on their cognitive functioning, improvement in functioning and find ways to help them function better. So that might be providing more structure. It might be helping with certain issues such as speech or finding a better way to communicate. And so those things might help. But I'll let Dr. Server actually answer your question a little bit further if he has anything else to add.
So, Jazakallah for the question. No, so they're not stagnant, right? Because as they get older, all the developments that happen in everyone, including all the physical, not just sort of like the mental development, but the physical development that happens. So their needs change, and and obviously, like I said, there's different stages, and so you might have folks who are quite brilliant as far as specific fields are concerned, academia is concerned, and then you might have folks that are completely nonverbal and remain that way. But so the people who are you know good or as in completely verbal and able to uh, you know, engage in their studies, etc., you kind of have to monitor them to see what their needs are with regards to kind of the social resources that they may need as they get older. Because, like I said, they might really excel in some things, but may really struggle in other things. So I don't think they get stagnant. I think it varies even for the folks who are nonverbal, obviously, because their needs as an adult change so much compared to when they're children, and the frustrations that they may face as an adult related to inability to communicate and engage in what we call societal norms, that may be very difficult for them. Yeah, so it's a population that requires s- constant attention and intervention and support. Unfortunately, it's not available for, especially for the adults. It's like a desert out there when it comes to the adult autistic population, because resources just seem to fall off of a cliff as soon as they turn 18. Something that we have to work on as a society. Exactly.
Jazakallah. You want another question?
And I just had a question for Dr. Sowar. So, since stimulants are first-line treatment in terms of efficacy for ADHD, is there any reason you would strongly consider a second-line agent, unless there was a contraindication or patient preference?
So patient preference, obviously, and then contraindication wise, any of the cardiac conditions that we talked about would be big ones to think about. Anything where, if they have an arrhythmia or an MI, or, I mean, obviously stimulants will cause fluctuations heart rate and also in your blood pressure. So, stimulants, and it will just require a much closer um, kind of observation for you to be able to prescribe a stimulant. Not that you can't, but it's going to be it's going to just require a lot more rigorous observation from the prescribing physician in those cases. The other thing I think about sometimes is, if they have comorbid depression and you're really convinced that the depression has kind of come in and caused the inattention, with inattention being kind of like the primary symptom of depression, then I would consider an antidepressant such as bupropion, to see if you can treat the depression and at the same time have that non sort of FDA approved second benefit of improving attention and giving them some more boost during the day. Um, but the other thing to think about also is that sometimes your patients do come in and they have a mental health condition such as bipolar disorder. Um, and they cannot be on a stimulant because there's significant concern that you have that they may um, have a manic switch, and the manic switch they've demonstrated very disorganized, very dangerous behavior in previous manic switches. So when you're thinking about a condition like mania, and I can describe mania in a second, you may not want to put them on a stimulant right away. So in that case, bupropion is, amongst all of the antidepressants, it's the least likely to cause a manic switch. And so you can give that um, as a non-stimulant agent to treat ADHD, or you can try atomoxetine, which is, like I said, it's an SNRI non-stimulant medication that is FDA approved for treatment of ADHD. Just quickly wanted to describe what mania is. So mania is in psychiatry, there are mood disorders. So depression is a mood disorder, and then there's something called bipolar disorder, which is if you have isolated depression and that's all you ever get in your life is different, depressive episodes. We call that unipolar depression. But we have bipolar depression where sometimes you get depression and sometimes you get the opposite of depression, which is sort of feeling like you're on top of the world, having a lot of energy, sometimes without not going to sleep for an hour or for an entire week, and kind of being very impulsive and risk taking and psychotic at times as well. And so in that condition, it's not a good idea to give stimulants, even if you are suspecting comorbid ADHD.
We have one more question.
Assalamualaikum. My name is Mariam Khan. I'm a rheumatologist. I have a question. So I think there's some speakers who are psychiatrists, like Dr. Gabriel Mate. I think I'm not sure if I'm pronouncing his name correctly, but I think he talks about ADHD as different from being just a genetic or inherited condition, but rooted in childhood stress and trauma as an adaptive mechanism or maladaptive mechanism. What are your thoughts on that?
So I agree that it certainly has impact from childhood trauma. In fact, one of the causes or one of the contributing causes of it can be childhood trauma. But, I think that there's a neurodevelopmental component to ADHD as well. So I don't think it's entirely trauma related in that way. I think when we think about genetics and sort of the development of the brain, ADHD, certainly there's roots of ADHD in that as well. So while I agree that trauma contributes, I don't disagree that I don't agree that it's entirely explained by trauma. I think that it's multifactorial, but I agree that it's it's definitely more commonly seen nowadays, or more commonly, I should say, identified nowadays. I guess the question is do we have more trauma nowadays? And I'm not so sure. Maybe, But I don't know if the average child is experiencing more frequent trauma or from a more traumatic home or has a more traumatic upbringing nowadays in a significant fashion that it could explain ADHD as a whole.
We have a question on the gentleman's side.
Okay.
Assalamu alaikum. I came late, so Naeem Ahmed, Family Medicine. So, how can we differentiate a phobia from a sensory symptom? How do we know somebody is avoiding food or something because of certain phobias, or it's a part of autism?
Yeah, so I think that so phobias are often isolated, right? So specific phobias, for instance, a fear of heights, a fear of needles, these things are going to be isolated, and patients will not necessarily have other symptoms affiliated with them, right? With autism, when you're thinking about it, the thing there's a difficulty with communication, right? There's a difficulty with um, uh, understanding social norms, right? And sometimes there's added um, intellectual disability as well, and so it's a collection of symptoms as opposed to an isolated symptom. So phobia is going to be typically isolated like that. So one of the ways to think about autism, and this is an old way and of thinking about it, is that the primary deficit in autism is empathy. And what I mean by that is not that um, folks with autism are mean, and they can't have empathy, but they are not able to, as they're interacting with you, kind of um, understand your expectations as far as emotional connection, etc. And so you may not get the type of reaction. They might think that you're expecting something else, and they might react in a way. Let's say that you're emotional about something and you're upset about something, and you're talking with them, they might not know that that's the way to respond, so they might smile or laugh or look happy when you're trying to look sad, right? um, and so when you're thinking about meeting with folks with autism, you'll understand these struggles that they're having. You'll understand, difficulty with eye contact, difficulty with social cues, different ways that they're trying to, with the lack of empathy, but also sometimes, I have patients with autism or autistic patients who will tell me that, their imagination and what they're engaging in is f- not only more interesting to them, their own thoughts, and their own world, um, they it's more comfortable for them as well. So you might be there and they might be kind of doing their own thing, and so not kind of acknowledging you or your attempt to interact with them, and that might happen as well, right? And so that's when I say, so there's a general sense that you're able to get from patients as well when you interact with them, whereas specific phobias, all of these other things, you know they're not deficits. You might see them, they might tell you about a specific thing that makes them very uncomfortable or makes them fearful, but everything else is intact. For which symptoms? For phobias? So exposure, right? So when you have folks with phobia, the thing that you want, that often we all want to do, right? Let's say you have a fear of phobia like bridges, right? So the thing that you want to do is you never want to go on a bridge again. Um, and so what happens is avoidance as is the response that we often want. It's the anxiety-ridden response that we often want to engage in. It's too uncomfortable, I'm not going to do it. What happens is that answer then starts to become the answer for other things. And so you avoid until you cage yourself in a box, right? So when you have phobias, the best way to do it is to have them engage in therapy where there is exposure. So you go to a bridge, with the patient, or you have them go with somebody, and then you have them walk on the bridge with somebody, then they walk alone, then they drive on it with somebody, then they drive alone, etc. So that's the best way to address any phobia.
Thank you, everybody, for joining us on this journey of neurodiversity. Again, you can meet with the speakers after the official program to continue asking questions. So thank you very much for this evening.